Today I am going to present my topic, which is PK-PD correlation, which is in the toxicokinetics. So this topic focuses on understanding the relationship between the drug or toxicant exposure in the body and the biological effect it produces. So it is important concept in toxicology, risk assessment, and drug safety evaluation. So PKPD correlation in the toxicokinetics. Before discussing the PKPD correlation, it is important to understand pharmacokinetic and pharmacodynamic. So, what is pharmacokinetic and what is pharmacodynamic? So, pharmacokinetics or a PK, which describe what the body does to the drug, which involves the absorption, distribution, metabolism, and excretion. While second is pharmacodynamic, which describe what the drug or toxicant does to the body, including its beneficial effect as well as toxic effect. So PKPD correlation establishes a quantitative relationship between the concentration of the toxicant in the body and the adverse effect it produces over the time. So this relationship helps to predict the toxicity and determine safe exposure limit and improve the risk assessment. So toxicokinetic, as we already discussed the two terms, pharmacokinetic and pharmacodynamic. So let's understand what is toxicokinetic. So first is definition. So toxicokinetic describes how a toxic substance moves through the body over the time, which includes the absorption, distribution, metabolism, excretion at the toxicological relevant doses. While unlike the normal pharmacokinetic, toxicokinetic often deals with the high or toxic doses where the body handling of chemicals may become non-linear. The main purpose of this toxicokinetics is to establish a link between the external dose and the internal concentration of a toxicant at the target organ. So this information is essential for evaluating toxicity and ensuring the human safety. Then ADME process in toxicokinetics. So how the body handles a toxicant when it get absorbed, distribute, metabolite and excrete from the body, as well as we understand the non-linear kinetics. So each pharmacokinetic phase directly influence the internal exposure and is critical for understanding the concentration and time profile of a toxic compound at the target organ. So first is absorption. So what absorption refers? It refers the entry of the toxicants into the bloodstream through the oral, inhalation, dermal or other routes. Second is distribution, which is the determine how the toxicants spread throughout the body tissues. Like lipophilic compound often accumulate in the fatty tissues, while other may selectively accumulate in the specific organ. So third is metabolism. So metabolism occur mainly in the liver, as we all know, by the cytochrome P450 enzyme. Sometimes metabolism convert a chemical into more toxic metabolites. That process is called bioactivation. Fourth is excretion. So excretion occurs through the kidney or bile and remove the toxic substance from the body. And fourth is non-linear kinetics. So at toxic doses, metabolic pathway may become saturated. As a result, small increase in dose can produce disproportionality, large increase in blood concentration and causes the toxicity. So second is pharmacodynamic, which which includes the toxic effect mechanism at the target site. So pharmacodynamic explains how the toxicants produce harmful effect. First is receptor binding. So many toxicants interact with the receptor, enzymes, ion channels, or nuclear receptor. The strength of this interaction influences the toxicity. That means how the affinity of the toxicant to the receptor, which influence the toxicity. So second is concentration effect relationship. The toxic response generally increase with increasing the concentration. So this relationship is often described using the Emax model, that is maximum concentration. So then third is toxic biomarkers. So biomarkers are nothing but as a we use the biomarkers for detection of the specific disease such as elevated the liver enzymes, cholinesterase inhibition and oxidative stress marker, which provides the measurable indicator of that particular toxicity. So this biomarker helps to assess the severity of that particular toxic effect and monitor its safety. Then we link the both pharmacodynamic and pharmacokinetic effects and how it relate with the toxic effect. So this slides demonstrate how exposure is linked to the toxic response. The sequence begins with the dose, the systemic concentration, target site concentration, and toxic effect. So several key PKPD parameters are used like AUC, which is area under curve, which measures the total exposure over the time. Then Cmax, which represent the maximum concentration reached in the plasma. EC50 and IC50 indicate the concentration produces the 50% maximum effect. Then Hill coefficient. What is Hill coefficient? Is describe the steepness of the concentration response curve. By combining these parameters, we can quantitatively predict the toxic outcomes in different individual and population. Then there are different models in the toxicokinetic for PKPD. So first is the direct effect model. So in this model, the effect is directly related to the plasma concentration without the delay. Then indirect response. These models are used when a toxicant influences the production or novel or removal of the biological response. Then third is effect compartment model. So this model explains delay between plasma concentration and the observed effect. A phenomena is known as hysteresis. Then PB PKPD models. So PB is nothing but the physiological based PKPD model. So physiologically based pharmacokinetic and pharmacodynamic models stimulate tissue specific concentration using a physiological parameter. So these models are widely used in modern risk assessment and regulatory toxicology. Then so exposure response and risk assessment, the NOAEL and LOAEL, that means no observed adverse effect level and lowest observed adverse effect level. So second, so it helps to identify this NOAEL and LOAEL. The second is therapeutic index. The therapeutic index compares toxic exposure with the effective exposure and indicate the safety margin of the compound. The third is species extrapolation. So using the PKPD model and allometry scaling, animal toxicity data can be translated to predict the human responses. So these applications support the drug development as well as the environment safety assessment and the regulatory decision making. So, a summary of this entire topic is nothing but the pharmacokinetic describes how the body handles a toxicant. Pharmacodynamic describe the toxic effect produced by the toxicant. Then internal exposure rather than dose alone drives the toxicity. Non-linear kinetic at high doses significantly affect the toxicity prediction. Then hysteresis must be considered when there is delay between concentration and the effect. Then integrated PKPD modeling improves risk assessment, dose selection, and regulatory decision making. So understanding where a toxicant goes and what it does in the body forms the foundation of the modern quantitative toxicology. So thank you. I hope this presentation provided a clear understanding on PKPD correlation in toxicokinetic and is important in toxicity prediction and risk assessment. I will be happy to answer any questions related to that. Thank you.